Next on Call, ask anything about gastrointestinal problems.
It isn't as bad as I really thought it was going to be.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Whoa, hard. Whoa, whoa, whoa. Keep pushing.
Let's try to take just your head.
Pull red handle to open bag.
Hello and welcome to On Call. I'm Tammy Watson. Gastrointestinal problems, you might call them GI problems, can range from upset stomach to constipation and diarrhea. And like a lot of personal complaints, health problems that involve trips to the bathroom can be difficult to talk about sometimes. Well, tonight is not one of those times. We're going to tackle GI health problems in our discussion tonight, and we have Dr. Timothy Ridgway and our medical editor, Dr. Rick Holmes, standing by, ready to answer your questions. You can call in to our toll-free number right now with your questions about gastrointestinal problems. That phone number is 1-888-DOCTOR-ON-CALL. Again, the phone number 1-888-376-6225 for questions about GI issues. And helping answer the phones and take your questions tonight are volunteers from the Brookings Health System. Dr. Holm, what's the most common GI problem that you see in your practice?
Well, I mean, the GI tract is, from the lips to the anus. I mean, it's from the beginning to the end. And it includes the stomach, the pancreas, the liver. And you can look at the vascular system that feeds the small intestine, the malabsorption story, the large intestine, the colon cancers, the stomach upsets, the heartburn, the infections in the upper system, the esophageal trouble, the heartburn, the reflux, the dysmotility, and the cancers as well. And then you can talk about tongue and swallowing and aspiration, and it's everything.
There's a lot.
I can't tell you I do colonoscopies. My father died of colon cancer. I'm very sensitive about that. We can talk about those things. This is a wide open, we've got a really excellent guest tonight to answer all those questions, so I really want you to call in tonight. I'm pleased to introduce to you our guest for this evening, Dr. Timothy Ridgway. Not the first time you've been on this show. Dr. Ridgway is the Dean of Clinical Faculty at the Sanford School of Medicine of the University of South Dakota and a gastroenterologist. Thank you so much for joining us.
Thank you for having me, Rick.
So you're originally from?
I'm from a little town in South Dakota called Ravinia, South Dakota.
Ravinia.
For all of our guests that really know South Dakota trivia, we'll find out.
Ravinia.
Ravinia.
So where's that from? Nearby.
That is right between Lake Andes and Wagner, southeastern South Dakota, right near the Missouri River, Pickstown.
Oh. So did you go to USD School of Medicine and then go elsewhere, or did you?
Yes,
what did you do?
That is correct. I went to the School of Medicine at the University of South Dakota, and then I did my residency and fellowship training in gastroenterology at the Mayo Clinic. Oh. And then I finished in 1991, and I have been in South Dakota since that time.
Great. And you're also on the Council of the American College of Physicians for South Dakota.
Yes, I am, and very proud of that, by the way. Very good organization.
That's right. And what do you think is your answer to Tammy's first question of what do you see the most?
I think, you have to understand that I'm a specialist to get referrals, but I can tell you that I think two of the most common conditions that are sent to me and that you as an internist see, number one, acid reflux disease where acid reflux is into the esophagus. But I think probably the most predominant and the one that's the least understood is the irritable bowel syndrome.
Ooh. And I want to tackle that one, so we should take a break right now, but the first thing we talk about when we come back is irritable bowel syndrome. It's just irritating me right now just to think about it. We'll talk about it right after this.
Over 10 million people are hospitalized each year for care of gastrointestinal problems, and the total health care cost exceeds $40 billion annually.
Ulcerative colitis is a disease that causes diarrhea, and it can also be the culprit behind anemia, weight loss, and rectal bleeding. Ulcerative colitis causes inflammation and sores in the lining of the rectum and colon. The symptoms of ulcerative colitis, may be challenging for some of us to bring up in casual conversation, but if we want a better understanding of the disease, we need to be open and talk about it, and that's why On Call had a great opportunity when we visited with one woman who wants to speak up and educate others about ulcerative colitis. It's a polite conversation about a topic that seems sometimes difficult to talk about. Gloria Pike is explaining what it's like to be diagnosed with ulcerative colitis.
I started having blood in my stool, and it just kept getting more and more, and so I went to visit Carrie, Dr. Holmes' PA, and she had me do different samples of and I'd bring in samples, and every time she'd call me and say, no, it's not in the stool, it's around it, so we think we're okay.
As Pike explains, a diagnosis of her problem took several months, numerous trips to the doctor to submit stool samples, and finally, an appointment with a gastroenterology specialist.
She did a colonoscopy and found out right away it was ulcerative colitis, and she said, you have a very angry colon, was her way of putting it.
Prescription medications help control Pike's symptoms, and she's learned to watch her diet, knowing that some foods cause flare-ups of cramps and diarrhea.
Lots of things that I cannot eat. I know I can't eat lettuce, that's for sure, because it causes kinds of stomach problems, and I have to be careful. Nuts, peanuts, and I love stuff like that, or anything with the skin on, grapes, apples, with, peel everything. And so I know that. Yeah.
Peel me a grape.
Peel me a grape, I know, it's no fun.
Another way that Pike manages her ulcerative colitis is by being aware of how her body is going to act on a regular basis.
Once I figure out what I can and can't eat, I can deal with that. I do know in the mornings I have to stay pretty close to the bathroom. That's my big time, just make sure that I don't plan anything early in the morning. Otherwise, I'm pretty good all day long. It isn't as bad as I really thought it was going to be. When I read, my daughter had gotten a lot of information off the computer for me, and I was like, this is horrible, but it isn't as bad as I thought it was going to be. It's, stay away from stress, make your life easy, keep busy. Keep busy is a big thing. Keep involved and just keep doing good things.
Doctors, one of the important things that Gloria mentioned to me is if you have blood in your stool, take it seriously and go talk to a physician.
I want to make sure that we say blood in the stool is not blood on the toilet paper. There's oftentimes they're going to have a little bit of blood on their toilet paper because they rub and they
bright red
scrub.
On the toilet paper, you're talking red.
We're talking about red toilet bowl.
And blood in the stool, is it always bright red, or is it?
Well, let's talk about that. Look at what's the color of the blood that comes from the gastrointestinal tract, and what would that give us?
Believe it or not, we talked about how we're going to be open tonight. There have actually been studies and published different colors of the stool and what it means.
Yes.
The bottom line is it can be bright red. Bright red blood in the stool, mixed in with the bowel movement, not in the toilet water, usually means blood's coming from the large intestine.
That means mixed in with the
stool.
Poop.
Yes.
Right, the stool.
Not the toilet water.
Not the water.
And that is significant because if you have a bleeding ulcer from the stomach and it's going through rapidly enough, it can
also
still
be red.
Bright red. The other type, though, we'll see dark red blood, and then black. And black stools are significant because that usually suggests that blood is coming from up high in the intestinal tract.
And why does that happen?
Because the blood mixes with the stomach acid, and there's a chemical reaction that turns it black. Now, I want to caution our viewers, if you take Pepto-Bismol, anything with bismuth in it, that also turns the stool black. But this is different. It's tarry, it's sticky, and people usually know there's a significant problem. But Rick, your point is well taken. Blood on the toilet water or blood that's dripping into the toilet water usually suggests an outlet problem, a fissure or a little tear in the anal opening, a hemorrhoid, something like that. And while it still needs to be checked out because you have to be sure there's nothing higher up, you can be a little more reassured than if you're seeing blood mixed in with the bowel movement or you're seeing black stools.
I'd ask you this, Tim. I've read somewhere, and years ago, that if it sits in there long enough, blood from the higher large part of the large intestine, and it's not moving slowly or moving fast, it's slow, it can turn black, and the source is still colon, even though it's black blood. Is that?
That is absolutely right. The bottom line is we can play the percentages, but you as a physician have to keep an open mind and realize that the point is there's something wrong and it has to be investigated. If you do an upper endoscopy, meaning looking down the stomach with black stools, and you don't see anything, that patient really requires a colonoscopy because, like you said, the problem could be coming from the colon.
Now let's talk about blood that isn't definable. Okay, Hemoccult test. I do a rectal exam once a year. I know there's a lot of debate about how effective that is in picking up prostate cancer and picking up colon cancer, but I do it in men in particular.
Okay, that's digital.
Digital meaning your finger, right? A digital rectal exam, feel the prostate, feel inside the colon. Sometimes you can catch a colon cancer by your finger, but you check it for blood. Well, out of the blue, here is significant blood in the stool. You test it with a chemical and you see. That's hidden blood. How often does Hemoccult positive stools mean that there is potentially a cancer of the colon, for example?
Well, I will tell you that we know that doing a digital exam and finding blood occult, or in other words hidden, is more effective in preventing colon cancer than doing nothing. Now, does finding blood mean you have colon cancer? Absolutely not.
And not having blood in the stool, does that mean that
No, that does not mean you don't have it. But the point is, it's something that at least needs to be looked at a little more thoroughly. If you're at age 50 or above and you have occult blood, your chances of having colon cancer are higher. And that would warrant, at least in my opinion, a colonoscopy to make certain that there's nothing going on. You can also look at other things such as the blood count. Is the patient's hemoglobin value low? That suggests you've got a significant problem. They're anemic.
Yeah.
So again, it's a matter of talking to your physician about it, and your physician should communicate with you. Take a good history. How have you been feeling? Has there been a change in the bowel habit? Anything unusual? You put all those things together, and then you talk with the patient, and together work out a diagnostic plan, no matter how intense you want that to be or not intense. You put all these things together to come up with a good plan.
I love how you say it's a plan that the patient and the doctor make together.
That is absolutely critical. It is, doctors are not there to tell you what to do. And I think that's really needs to be emphasized. This should be a partnership. It's a partnership between you, the patient, myself, the physician, and let's talk about your symptoms, and then let's talk about what could be going on, what's not possibly going on, and what kind of things we can do to come up with the appropriate diagnosis.
Right. There you go.
Well, I know you gentlemen have a very interesting discussion and some interesting things about, you mentioned colonoscopies. So let's talk about colonoscopies. Are they really such a crucial screening tool? What does a patient need to know going into a colonoscopy? What are the recommendations? And then we'll dive into questions that are coming in.
Of course, right now everybody's hearing that they need to have a colonoscopy at 50. That's the thing, right? And then every 10 years, if it's normal, as a screen until you're 80. What do you think of that recommendation?
Well, screening colonoscopy is, for good reason, is getting a lot of press. And initially when it came out, we predicted. We didn't know, but we predicted because we know that colon cancers start as polyps. that it made intuitive sense if you picked it up in the polyp stage, you could prevent colon cancer. But we had no data that screening colonoscopies actually prevent colon cancer until recently. But the surprising finding is that we found out we were very good at preventing left-sided colon cancers, about 80% less chance. But in the right side of the large intestine, only 50%. And that raised questions. That raises questions. And here comes the rub. All colonoscopies are not created equal. First of all, it's the prep. And you know, patients, I've had a colonoscopy. Rick,
I've had several
we've had them,
colonoscopies.
so we can talk about this. The worst part about this procedure, and I think our audience will agree, is the prep.
Okay, so that's the medication that a patient has to take. They get diarrhea, it cleans them out so that you can actually see what's going on.
Yeah, you don't want to go up there and there's all sorts of poop in the way. You know, you want to be able to have a clean colon, and the prep prepares.
And if that prep is not clean, and the endoscopist says everything looks fine, we'll see you in 10 years, things can be missed. We've also learned that there are different things. For example, the withdrawal time. From the time the endoscopist reaches the end of the large intestine, which is called the cecum, and the time it takes to come out, if that time frame is less than 6 minutes, we know that there is a substantial risk of missing significant cancers. Today, 6 to 9% of all colon cancers picked up by colonoscopy, these patients had a colonoscopy within the previous 36 months. So what that tells us is we need to be more meticulous. Your endoscopist needs to be meticulous about how they're doing the examination.
So that's how much time the endoscopist is spending looking through the scope.
There was a wonderful study. It was 25 gastroenterologists in one group, and they said, let's study how we do it. And they monitored the time, how many got to the cecum, how much time it was to get to the cecum, how much time it was to get out, and how many polyps were found, how many cancers were found. And the direct correlation with the amount of cancers that were discovered and lives saved had to do with how much time the colonoscopist took. It really wasn't the training, except the training should be part of that, to train the guy to take some time.
Exactly. It makes intuitive sense. You've got to be thorough. And the other thing we found, we know now based on large numbers of patients that all women that have colonoscopy, that endoscopist should, at least 15% of patients, be finding the precancerous polyp called the adenoma. In males, it should be 25%. If those numbers are below those levels, then the feeling is that that endoscopist is not doing the quality job. So our listening public tonight, if you want to get very critical when you're having your screening colonoscopy, ask your doctor what his or her adenoma detection rate is, and you'll get a look. But there are actually insurance companies now that are going to be looking at this, and they're going to say, you know what, if someone's falling below these numbers, we may not be covering for that procedure.
That's right. Now, I have often said, and this is an old statistic, but I say it to the patient, if I find a polyp and I remove it, it's an adenomatous polyp, then there is a 40 times reduction in the risk of colon cancer in your case. Now, I know that sounds really pretty good. What number do you say?
Well, a lot of it depends on the size of the polyp, and the number you're saying is correct. If that polyp is greater than 1 centimeter in size, or about a half an inch. Polyps below 1 centimeter in size, we really don't know the significance if we're truly making a difference. But that number is actually quite accurate when you're looking at the polyps that are 1 centimeter or larger in size.
You know, in my experience, I'm now, 30 years doing this, and I have a good number of people that are second, third, fourth colonoscopies, because if you have more than one polyp or you have a large polyp, you're going to need to do them in 3 years. If you only find one small, 5 years, and then 10 years if you don't find any. I have found that if you remove those polyps, they aren't their number next time is much less than the third time. It's almost gone, and I put them on a baby aspirin a day. Let's talk about that baby aspirin. The New England Journal article said baby aspirin is better than a full aspirin in preventing colon cancer, or polyps anyway.
Yeah, and it's somewhat controversial, because you're right. We have found that there's agents in aspirin that can be preventative for colon cancer. But what I don't want our listeners to take home from that is everybody has to go out and take an aspirin, because The other thing is, you know, Rick, that baby aspirin a day can do is increase the risk of other problems. Bleeding, ulcers, bleeding into the brain, those kind of things. Just like the heart attack data, where we knew an aspirin a day could be helpful in selected patients. But if you have a history of ulcer disease, a history of other types of bleeding issues, that risk of having bleeding from taking that aspirin a day could overtake the risk of colon cancer.
But I would counter to say, and I've looked at that data on the aspirin and the heart disease, it's about a push for heart disease. You know, it causes as many problems as it solves, but it does solve some problems too with heart disease. It's close of a push. On the other hand, it isn't a push with the colon. As long as there isn't an ulcer problem or a bleeding problem, and there isn't I'm quick to put them on a baby. And I like a baby aspirin over a full aspirin. The studies supported the baby aspirin.
I agree.
Okay. We've got questions coming in already. So the first one from Bison, South Dakota, 57-year-old male. What would cause a large amount of mucus in your stool?
Well, we're going to get to irritable bowel syndrome.
Yes.
So let's talk about mucus.
I get that complaint a lot, and it really frightens patients when that occurs. But I'm here to say and to be reassuring that most of the time that's not a worrisome complaint. I would take that complaint and then follow up with other questions. Has there been a significant change in bowel habit? Has there been weight loss? Has there been blood in the stool? Those are kind of alarm symptoms that we look for. But seeing mucus in the stool alone is not necessarily an abnormality, and that gets us to the discussion of the irritable bowel syndrome, which...
But before we do that, it does say that there's some inflammation going on, does it not?
Well, not necessarily inflammation, irritation, I think would be a better word. Inflammation is something like our patient with the ulcerative colitis, where you actually have blood, you have an invasive change of the lining of the large intestine. With mucus, it suggests that there's some kind of irritation, but there may not necessarily be a denudation or invasive tearing of the large intestine lining.
Right. Okay. So mucus, though, generally suggests IBS, irritable bowel syndrome.
Correct.
So let's talk about it. I interrupted you. I apologize.
Well, irritable bowel syndrome. You know, it used to
catch
be.
bag?
It used to be called spastic colitis and functional bowel disorder, and there were so many names for it. And it used to be a garbage bag term, to be honest, as you know, Rick. People used to come in with complaints. Doctors couldn't figure out what it was, so then they would say, well, it's just your irritable bowel, go home, you'll be fine. What we've learned now is that you can make that diagnosis proactively. You come into the office, patients have complaints. We always look for alarm symptoms, symptoms that make me say, uh-oh, there could be something. Blood in the stool, trouble swallowing, weight loss that you're not intending, a marked change in your bowel habit. Patients with irritable bowel syndrome actually live a normal life expectancy, but it can be very debilitating. And there's a variety of causes we're learning. The motor function of the gut is one.
That's the muscle
That's
function.
the muscle and how it propels food through the digestive tract.
I'm interrupting you. A question from Rapid City about a 74-year-old female about irritable bowel syndrome. What causes it? Nerves? The food you eat? What?
The motor disorder is one where the motility or the coordination and movement of food is altered. Stress is kind of a more overall term that we know that there's an interaction between the brain and the gut. People that tend to be nervous can have more of those problems, but there are many people that do not have anxiety to any degree and still suffer from this.
And there are people with tons of anxiety and they have no problem with their bowel.
Exactly.
So it's a non sequitur, you know, it doesn't fit, right?
Right.
I don't think it's an anxiety deal.
No, I don't either, and I think that stress is overplayed in this condition. We know there's another term we call visceral hypersensitivity. That's the irritable bowel patients that have pain. But what it is you and I are sitting here now, and our intestinal tracts are working, and we're not having pain.
They're doing
but some patients, here in my threshold might be here. The irritable bowel patient's threshold for pain may be way down here. So they will get distension, and they'll hurt. They'll have cramping. And does that mean that patient is a wimp and Rick and I are not? No, it just means that threshold is lower. And now there's looks at new novel medications that can help to raise that threshold that actually can be beneficial in this disorder. We can have a diarrhea predominant irritable bowel where the main complaint is diarrhea. Other patients' main complaint may be constipation. And This is the #1 cause of patients to see gastroenterologists. I think the problem is, unfortunately, our specialty tends to do a lot of tests, a lot of stuff, and then says, well, it's irritable bowel, go home. And we're doing our patients a disservice. It's education. We need to sit down, talk with them about what it is, what it isn't. Here's what I think we can do. And you know what the #1 best shown treatment in studies for irritable bowel syndrome is?
What is it?
Regular visits to your physician for reassurance, to sit down, listen to the complaints, what's new, let's adjust some things, let's monitor you. And that has been shown to prevent doctor shopping. Well, they didn't find this, so I'm going to go elsewhere and see if I can get this
So there's
found.
another doctor you go to and another
Exactly.
doctor, and I thought some of them get better off of milk. Some of them get
Yes.
better gradually bringing them into fiber. Some of them get better with a regular exercise program. None of it's very magical. It's not pills.
You just hit the point, though. Everybody's different. And one size does not fit all.
Yeah,
you
right.
have to adjust to the patient's complaints. That's exactly
Any
right.
herbals that help on that?
You know, I have not used a lot of herbals in my practice, but that's simply because by the time patients are referred to me, they've usually tried those. Have you tried anything that you found effective?
No. I sometimes if there is a depression in this group,
Yes.
and I said, this is, but sometimes an antidepressant will help. I certainly think a regular exercise program.
That's huge.
Huge.
That's huge.
Yeah.
It really is.
Okay. Well, we're going to move a little further up in the body to the stomach for our next story. Proton pump inhibitors are a type of drug used to treat heartburn and excess stomach acid. They're commonly referred to as PPIs, and On Call spoke with a pharmacist to learn more about these medications, how they work, and their possible side effects. Nexium, Prevacid, Prilosec, you know the brand names. These are common PPI medications, and Brittney Meyer, assistant professor of pharmacy practice at South Dakota State University, says these medications work at the molecular level in the human body.
So your stomach produces acid to help digest food, and there's a molecule in certain cells of the stomach that pump hydrogen ions into the stomach, and that's called the proton pump. And hydrogen ion is what makes the environment acidic. And so proton pump inhibitors block the action of that pump, so hydrogen ions can't enter the stomach, therefore decreasing the acidity of the stomach.
Meyer says that recent research has attempted to clarify whether or not the likelihood of certain illnesses, like pneumonia, is related to PPI use.
The thought behind the process with pneumonia and the C. diff infection is thought to be due to the decreased acidity in the stomach because of the PPIs, which is their intended use. However, with decreased acidity, some of that bacteria that was killed off may now remain. And then when you sleep and lay down, some of that stomach juice can creep up the back of your esophagus and get into your lungs.
C. diff is another disease that might correspond with PPI use. It's a type of bacterial infection that causes severe diarrhea. Some scientists suspect that less acid in the stomach makes an environment hospitable to an overgrowth of this bacteria. However, according to Meyer, scientific literature is not clear on whether or not the correlation between PPI use and the occurrence of pneumonia and C. diff infections actually exists.
Again, like I said, the studies were conflicting, and some reported them and some didn't. So the amount of risk is small. However, it could be there.
The second major cause for ulcers is irritation of the stomach arising from regular use of nonsteroidal anti-inflammatory drugs, or NSAIDs.
Thank you for joining us tonight. I'm Tammy Watson, and we're talking about GI problems. Here live in our studio are Dr. Timothy Ridgway and the on-call medical editor, Dr. Rick Holm. They're ready to answer your questions, so you can call in right now. Our phone number is 1-888-376-6225. And at the beginning of the show, I said we'd talk about anything, and we have a phone call about gas, and basically a gentleman dealing with loose stools, smelly gas, 75-year-old. What can you do when you have bad gas.
Well, of course, you know that only guys pass gas.
Oh.
And it's generally pretty extensive.
I thought they only had dogs that,
the dogs
they
pass
stand
gas.
next to dogs.
That's right.
Yeah.
The dogs get kicked and everybody's happy, you know.
Yeah.
That's a great story. But the guy passes gas, the dog runs out of the room knowing full well he's going to get kicked.
So what do you do if you have a...
So, I mean, my sense is that there's more of this as people get older. They don't absorb as well for, you know, just because everything doesn't work quite as well. Yeah. And you see a lot more smelly gas as they get older. And it depends upon what they're eating. And if there is a malabsorption syndrome. Tim, any comment about rectal
Well, yeah,
gas?
I mean, you know, gas is a complaint. And some patients are a little bit cautious to complain about it. When they come in and do, I always take it seriously. The first thing you have to do is make sure there isn't something significant like a malabsorption. There's something called lactose intolerance.
Yeah, milk intolerance.
Milk intolerance, it's a component. Our intestine has an enzyme that will break that component down in milk. And in some individuals, that enzyme can lose its function or they won't have good function to begin with. As a result, this carbohydrate that contains this doesn't get broke down and creates gas and can cause loose stools. There are things like overgrowth of bacteria in the small intestine. If people have slow movement through their small intestine, that can do it. Now, having said that, again, this is where it comes down to a good history. And if I'm sounding like a professor, that's because I'm drilling this on my students all the time.
Well, you are.
But they have to take a history. And with this gentleman, you know, has there been weight loss? Does it wake you up at night? How bad is the diarrhea? Are you seeing blood? Now, I will tell you, and I think, Rick, maybe you've seen this as a primary care doc, far and away the majority of the time can be related to dietary changes. And I'll tell you one, is that eating too fast. When we eat fast, the stomach in some individuals just can't handle it. It tends to distend, which creates a feeling of bloating and gassiness. I've always said, and I tell patients this, our intestinal tracts were not developed for 3 meals a day. They were developed to small amounts, eat small amounts all day long. But our social schedules dictated 3 meals a day, and frankly, I think in this day and age, sometimes it's 2 meals a day or even 1. Yeah. Most people can handle that, others cannot. So if you've taken a careful history, a careful dietary history, you don't find any abnormal findings, I suggest first thing, just slowing down, avoiding some of those foods that can be more gas-forming, some of the raw vegetables, the lettuce, things like that, and then following up to see if that makes a difference. If it does not, then you can start doing a little bit of testing to make certain that nothing else is occurring.
I think it was in the 80s I read a study where they measured the amount of gas.
Yes.
They found, amazingly, that girls passed the same amount as guys passed. It was true. I was aghast.
There was a professor who made his living on that. His whole career, he actually spoke to us in training. He made his career on intestinal gas, and he had more jokes than you could ever imagine.
No,
but I wanted to say that one of the articles had suggested that the biggest causes of gas include milk, the root vegetables like carrots and beets and whatever is roots, turnips and so on and so forth. High fiber and fruits. Well, if you think about it, the gas formers are really I always say, well, it must be that you're eating correctly. So, burping is another story, but aerophagia, people who swallow air when they're eating, it's that fast eating.
That's that fast eating. They're eating so fast, they're swallowing air as it goes with, and it can cause trouble.
And that just kind of moves on the way through. And
correct.
Right. We've totally covered that.
That's enough on gas.
Okay, we can move on. Question from Beersford, female, age 68. She has celiac disease. How important is it to have family members checked, and should you wait until there's symptoms?
Let's talk about celiac. What is celiac disease, Tim?
Celiac disease is a disorder of the small intestine. And basically, the small intestine, the higher part of the small intestine, cannot absorb food that it ordinarily can. And the reason for that is it's an allergic reaction to an ingredient that's in a lot of the food we eat. It's called gluten. And it's in wheat products, it's in a variety of things. Now, my answer to this viewer is absolutely your family should be checked. We now have ways of checking without having to do an endoscopy and a biopsy of the small intestine. There's a blood test, particularly in family members, that can be done to determine if they have this. Now, the reason it's important, we're learning, to do this before symptoms occur is that we think if we catch this early, perhaps even before symptoms develop, we might be able to prevent the long-term complications of this disorder and even prevent the symptoms from actually starting. Those being diarrhea, weight loss, gas. There's that word again, because lactose is one of the things that's malabsorbed when we have celiac disease.
So anybody who presents, and I think this is the clue, anybody who presents with irritable bowel syndrome, and if you're out there and you have been told you have irritable bowel syndrome, you should have had the tissue transglutaminase blood test, which is the TTG screening blood test for celiac disease.
We've learned we've underdiagnosed this in many patients. They would come in and would be labeled as the irritable bowel syndrome, and we actually, when they were checked for celiac disease, had that. So you're right, Rick. I think that before we complete a diagnosis on someone and tell them about irritable bowel syndrome, we should consider that diagnosis and have the blood test done.
Although I can tell you also celiac disease can present unusual ways or not at all. I mean, and so a family member can have it. They did one great study. Family members who had no clue, feeling just great, no problem, tested them, they had it. They've said, okay, we're going to put half of you on a celiac diet and the other half on a gluten-free diet, and the other half just leave them be. And all of them were just fine, right? The ones who went on a gluten-free diet, they were better than better. They got better. It was worth going on a gluten-free diet. But it's got to be an all or none thing.
Exactly.
Now, if it, we're talking about symptoms here, but what are the long-term impacts of untreated celiac disease?
Tim, you would agree to that.
And I don't want to, first of all, it's just malnutrition. You can get vitamin deficiencies and therefore be more prone to fractures. Now, the dreaded complication from long-term disease that goes untreated is actually a cancer of the small bowel called lymphoma. Now, that's rare, and the majority of the patients with celiac do not get that, but we are also learning that if we can treat these patients adequately, we feel we can make a difference in that complication coming to fruition. Anemia, fatigue, and it's like you said, Rick, it's just simply not feeling like yourself.
I had a guy who had a kind of a bloaty gut thing. He couldn't take lettuce. He loved pizza, did great, but he presented with a peripheral neuropathy, which was, I think, B12 deficiency.
Okay. Yes. Again,
and,
that is...
and numbness and tingling in the fingers and the feet. And I'm going, well, I mean, I got to check your thyroid and your B12 level again. And he said, well, do you think it could be related to the fact that my sister has celiac disease? And I went,
there it is. Yeah, there it is.
There it was. Another guy presented with iron deficiency anemia.
Yep.
Just came out, and I was sure he had colon cancer. Did the colonoscopy? Nope. So I sent him up for an EGD. They biopsied the small intestine, and it came back kind of a weird answer. And I thought, whoa, could this be? Celiac test was positive. We put him on a celiac diet. Gained weight. Had lost all this weight, and iron anemia went away.
Yeah, and that's because iron is absorbed in the small intestine. And if the small intestine can't absorb, you don't get iron from the meat and stuff we eat daily, and you need iron to build up red blood cells, the count goes down.
Yeah, it's a great disease. I mean, it's great fun.
It's fascinating.
I keep thinking, Tim, that there, for ulcerative colitis or Crohn's disease or some other malabsorption things, we don't know what it is.
And
there's something like celiac disease there. Yeah. It's something that they're eating or something that we could easily change. But we don't know what the answer is.
I completely agree with that.
One final question about celiac disease. The cause? It's just genetic?
Inherited.
It's inherited. Yep. We've actually isolated certain genes that predispose individuals to have this disease. And that's why, for the viewer, I think having your family checked would be a very good idea.
Okay. All right, a question from Menno. What is the best prep for colonoscopy? So back to, there's different kinds.
Yeah.
What are the different kinds?
Well, we used to use fossil soda, and you don't use that anymore because it can cause a bad kidney problem. So we've all switched. And I know some guys are using the gallon of Go Lightly or the Movie Prep or whatever that is. Ooh, it's awful. And we use the mag citrate, a little concentrated bottle of mag citrate at our hospital.
And the other thing I want to point out, I think that's a very good question. The thing we're learning again in terms of looking at what is a good prep is splitting the prep, the split dose. Now, if you're living far away, for example, you're 2 hours away and you come in to have your colonoscopy, it's kind of hard to take half your dose the night before and then half the dose the next morning. Rick, for your patients in Brookings, what we're finding is, for example, if you're going to take the full gallon of the Colite prep, 2 liters or half a gallon the evening, and then 2 liters the morning of the exam, the preps are much, much better. You don't have that murky stuff that in the right side of the large intestine. And I think that's why you're preferring the megcitrate. First of all, it's smaller volume. Second of all, it tends to be less harsh, and we're getting cleaner preps. Now, do you give it all the night before, or are you splitting
we
it
split
up?
it. Just like
See, there you go. There's the split dose.
We take it at night, and then the next dose.
That is very, and I think that's why you're seeing good preps. We're learning that if you take everything the day before, that left side of the colon will be pretty clean, but you get to the right side and it's just not going to be as adequate. So for patients that are having their colonoscopies later in the morning or early afternoon, it's perfect. For patients that are having it at 8 o'clock and they have to drive 2 hours, it can be a challenge, to the point that we even suggest if they have relatives, come to town the day before, stay with them, and split the dose. So there's a lot of good preps out there, and as Rick said, the old Fleet's phosphosoda, anything with that phospho in it,
it's out.
It's dangerous. Kidney problems, whatever. So talk to your doctor. There's more than one prep, and talk to them and say, look, I want the most effective prep. That may not always equate into the most comfortable, and I just tell myself there is no comfortable one.
No, there's no.
So you might as well grit it out and do it right, so you don't have to repeat.
We go clear liquids for a full day, maybe 2. Do you?
Yeah. I do. I think clear liquids is very critical in the process.
I had one lady that she was just did all things exactly right. She was not cleaned at all. And I thought, my gosh, you didn't take the prep. I took it. So the next time we did it, 6 months later, she had 2 days of clear liquids and 2 days of prep, full prep. She was still not very clean, although we went another, I think, 3 years. 3 days of clear liquids. I think we gave her the first prep 2 days earlier. I mean, all that. But she was clean.
No, you set me straight on something once. I had the idea that fiber makes stuff move through. Fiber would be good, but no, not for prepping for a colon. That's the wrong thing. Clear liquids and then the prep stuff.
Well, speaking of fiber, Tim, I have become the guru of, I mean not the guru, but the promoter of Wonder's Golden Flaxseed from Howard, and promoted that nice, really nice, nutty flavored stuff, and then we grind it in a coffee grinder and put it on our cereal at night, every morning, and it's really been a delightful addition. It greases the skids, is how I put it. What do you think?
I completely agree. And, you know, we talk a lot about the fiber you can get over the counter, the Metamucils, the citrus helves, but it's the natural fiber in foods that really, in my opinion, can be the most effective. And it's like you said, it's a matter of getting some flaxseed, spreading it on your cereal, what have you. And I have to admit, it was my nurse for years in gastroenterology that really started saying to me, you need to look into this flaxseed. It's the greatest stuff on earth. In which case I did, and in which case we do have some data that shows that it can definitely increase stool weight. It's a natural product. There's no side effects. And you don't get all that bloating and gas that you get sometimes with the artificial stuff that you get.
Now I promoted Fiber One breakfast food or you know, these little terribly tasting, you know, things for a while. Well, they've got better flavored stuff now, but I promoted tons of Fiber One and was an advocate myself. But the stool was sticky, and you add the flaxseed and it's greasy and it goes. So we're happy about that.
Okay.
That's just add a little that Fiber One, that little ground flaxseed in there, and it makes it work better.
Fiber and ground flaxseed.
Yeah,
right.
You would think I would be embarrassed.
And don't forget lots of water. That's the other key here. Hydration is very important. Patients think that they can take lots of fiber and it's going to be okay. But if you're drinking coffee all day or soda pop and you're not drinking the water, it can be a real issue.
Well, yeah, let's spin this around. We're talking about healthy things to eat. What are bad things that are going to plug me up? And
I think
cheese or
overprocessed. Overprocessed food. Cheese, I think milk products are great if you don't have a problem.
Okay.
But I like fruits and vegetables, and then there's fruits and vegetables, and then you really should eat fruits and vegetables, and then that ground flaxseed.
I always I sell this to my patients all the time. The incidence of the irritable bowel syndrome, constipation, diarrhea in this country was quite high compared to Eastern countries where it was almost non-existent. All of a sudden, we started seeing an increase in incidence in the same kind of bowel problems. And guess what it coincided with? Fast food shops setting up in Eastern countries. And so, you know, there's a clear correlation. It's the fatty foods, it's the processed foods, a lack of fruits and vegetables, lack of fiber that creates a lot of our digestive problems.
I just read an article in the Archives of Internal Medicine, it was like 2 months ago, that looked at fiber, and they found a decreased death rate in the people who were eating high fiber. And it was heart disease reduction, cancer, overall mortality, cancer reduction, heart disease, a higher correlation than cholesterol issues, than a whole variety of things. And it moved me towards high grain bread, right? I immediately changed my bread.
It's true. We are what we eat. And I think in my specialty of gastroenterology, that's very, very true.
Okay. Switching gears totally, and we've just got a little time to talk about this. Barrett's esophagus is also something that you gentlemen wanted to bring up.
Yeah.
What is it? And
Barrett's.
You want to say what it is, or?
Well, it's the lining of the stomach that as there's a chronic reflux of acid into the esophagus, the lining of the stomach seems to have moved up into the esophagus to protect it. However, for some reason or another, that kind of nice gastric protective tissue in the esophagus can turn to cancer. Now, would you describe it easier?
Yes, and there's a lot of misleading information out there on Barrett's esophagus, and a lot of things have been said. Oh my God, you've got Barrett's esophagus, we need to cure you, you need a surgery for anti-reflux to prevent it and that type of thing. And I think that to clarify for our listeners, and this is the best way to describe it, we know that there's an increased risk of cancer of the esophagus and Barrett's esophagus. The terms that I like to use to give patients an idea, us three in this room, assuming we don't have Barrett's esophagus, have a risk of getting this type of cancer about 1 in 1,000. If you have Barrett's esophagus, your risk of getting cancer of the esophagus is 5 in 1,000. So it's increased, but it's not dramatically increased. And the important point there is, if you're diagnosed with Barrett's, it's not a death sentence. And in fact, we recommend now endoscopic surveillance, meaning we look periodically to biopsy and look for cellular changes. But we're learning that we're picking up very few. I mean, that people are saying, is it really cost effective doing all these? Now there's technologies coming out where we go down with an endoscope and a probe and we literally burn the Barrett's tissue to get rid of it. Now we know if you have those cellular changes, meaning, boy, that's a sign, as you know, Rick, dysplasia is the word we use.
Yeah.
That tells you get rid of it. And we know we can make an impact on those patients. The controversy right now is, should everybody with Barrett's get this ablated and removed? It's high cost. There is some risk. I think the answer is still out there. There's doctors saying do it. There's others saying no, let's wait until we know more. Right. But I think the point for our listeners is Barrett's esophagus is real. Yes, it does increase your risk of cancer, but quite honestly, your risk of dying from other causes can be just as high, if not higher, and it takes that conversation with your doctor.
Keep an eye on it, right?
Right.
Okay, we're running out of time. We got maybe 20, 30 seconds of parting words of wisdom, Dr. Ridgway.
You know, I think the parting words of wisdom for me is, you know, we talked earlier, and you've heard us talk tonight about things that people don't like to talk about. And if you have a problem in your digestive tract and you're concerned about it, you should not be embarrassed in any way, shape, or form to go to your physician. That's what they are there for. We are trained to listen to those kind of things, just like we talk tonight.
Okay.
And I want to thank you, Tammy. This is your last show. I want you to know how much I appreciate all that you've done. We're going to miss you.
Thank you. And we will be back with the Open Perspective and What's New in Medical Science.
Looking for reliable healthcare information online? You can start with the resources link at the On-Call website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
Several years ago, a comedy TV show on Saturday night parodied high-fiber breakfast cereal, calling their fake brand Colon Blow. At our house, that's what we call our fiber breakfast cereal mix, topped off with ground flaxseed and dried fresh fruit. There's a good reason I promote high fiber, but there's an additional point to make. Many of my patients, especially the elderly, struggle with constipation problems. Very often these people have been taking one stimulant laxative or another, such as Senna or Casantrolol, and have been doing so for many years. Specialists have known for a long time that stimulating the bowels with an irritant only works for a short while, and then a higher dose is required, and then a higher dose is required, and so on. What's worse, following the use of bowel stimulants, commonly there is diarrhea, and then rebound constipation when these drugs are on an ebb or stopped. Thus, many people have had a roller coaster bowel problem for a very long time as a result of using stimulant laxatives. But in a controlled environment like a nursing home, I've noted that when the stimulant laxatives are stopped and we provide enough fiber along with as-needed osmotic non-stimulating laxatives, the problem goes away in about 2 weeks. Here's the formula. Number 1, start with enough fiber. I generally recommend food fiber, such as brand types breakfast cereal or oatmeal rather than packaged type. Another good source is ground golden flaxseed, which has an additional fish oil type benefit. Start slow and increase gradually. 2, if needed, add plain stool softeners. 1 to 3 capsules once or even twice a day, 6 at the max, might do it. Adjust dose daily to balance the bowels. Avoid softeners when in combination with a stimulative laxative. I repeat, don't use stimulant laxatives. Number 3, if still no success by the above, add one of the following: milk of magnesia, polyethylene glycol or Miralax, or sorbitol, but only when needed. All 3 work by drawing fluid into the bowel rather than by irritating it. Well, fiber is the most important part of the formula, and new science shows significantly reduced overall death rates in those who eat enough fiber. So, as the TV comedy skit goes, I stay regular with Colon Blow. You can too. We'll be right back.
In our medical news tonight, Ebola virus is pretty rare and very fatal. It's the cause of Ebola hemorrhagic fever, and like anthrax and smallpox, it's classified as a Category A bioterrorism agent by the United States Centers for Disease Control and Prevention. New research has identified a specific protein that the Ebola virus uses to gain entry into cells, and this discovery may help in the development of drugs and therapies that can treat or fight off this very lethal virus. At the United States Army Medical Research Institute of Infectious Diseases, genetically engineered mice were tested, and mice that did not have the genetic makeup to create this gateway protein were largely protected from the Ebola virus. And in other news, when an individual with depression takes an antidepressant and that medication fails to help, the patient may move into a state of remission, a second medication may be prescribed. Researchers at the University of Texas Southwestern Medical Center at Dallas have recently reported the results of a study that says exercise can be just as effective as adding a second antidepressant medication. Study participants who ranged in age from 18 to 70 years old were divided into 2 groups. Each group performed different levels of exercise, and at the conclusion of the study, scientists found that moderate exercise was more effective for women with a history of mental illness, and intense exercise was more effective for women with no family history of mental illness. For men, a higher rate of exercise was more effective across the board. And on that note, that's about our time for this evening. Once more, I'd like to thank our guest, Dr. Timothy Ridgway, and the on-call medical editor, Dr. Rick Holm. Thanks to our phone volunteers, and thanks to you for watching and for calling in. Have a good evening.
for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by on-call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Bio Communications at South Dakota State University.